appreciate you for the presentation. I want to thank the executive and leadership of Nigeria Society for the Study of Pain for inviting me to give a very important lecture this evening. And so today we have before us management of chest pain. I want to welcome everybody to this lecture webinar, and I hope I will be able to do justice within a very short time.
Thank you, Professor Kulu. Is it possible for you to put on your video?
Okay, I'll put on the video now.
Thank you.
Oh. This recording is blocked. Okay, it's blocking some things. Let me just say, okay.
Yes, we can see you now.
Okay. So,
continue, please.
Okay. So the scope of lecture, we'll talk about chest pain, types of chest pain, differential diagnosis, pathophysiology, and then evolution of risk factors for coronary artery disease. Before we talk about a little bit of coronary artery disease in Ilorin, then we talk about spectrum of presentation, investigations, and management. So by way of definition, chest pain is a form of discomfort in the chest area, and it's of different types. And I want to say that the presence of chest pain is a lot of stress to managing physician and also to the patient. And this is because they don't know what is really happening in the chest. Is the chest pain related to musculoskeletal disorders, or it is more related to some serious underlying condition? So it generates a lot of anxiety and worries in the patient, and not only in the patient, also in the physician, because many of the conditions causing the chest pain may not necessarily be associated with a lot of heart problem. Indeed, they are probably very innocuous cause. And then we have some that are associated with serious underlying problem, which as a physician, you don't want to miss, because that could generate what I would call medical legal problems. So you have to differentiate between these two as fast as possible so that you'll be able to intervene and manage the patient appropriately. Because some of the causes of chest pain may actually warrant or may desire immediate intervention in order to save the life of the patient. And we know fairly well, using Bayes' theory, which says that the probability of a positive test predicting those with the disease will actually depend on the knowledge or the presence of condition in the population. For example, we know that chest pain is very, very common in Caucasian population. And most of the times, or many of the times, they are associated with coronary artery disease. All right. However, in our own environment, Negro population, especially, let's say, sub-Saharan Africa, many of the causes of chest pain may not necessarily be associated with that condition. Although we said that the incidence of coronary artery disease is increasing, the prevalence is still on the low side. Although, unlike what we have before, it's increasing in the frequency. But especially in younger individuals, many of them, we present with chest pain. And by the time you have done investigations, ECG, you have done echocardiography, only very few of them will have positive findings on all these investigations. Many of them actually do not have much sinister problems, but you have to differentiate that from those who have serious problems. And that is why it resulted into either doing a lot of investigations to be sure that we have done enough in order to identify whatever is causing the problem in the patient. And some will do well on simple analgesics. And once they get that, the treatment can actually be okay. Whereas for those who have coronary artery disease, one has to really painstakingly manage the patient and intervene at the right time. And the intervention will definitely address whatever the patient is presenting with. And that is actually to save the patient's life. And if it's not done on time, I want to say that that time is muscle. Meaning that if you don't intervene on time, even if the patient survived the myocardial condition, either what they call it, unstable angina or myocardial infarction, they will end up having complications, which is avoidable. And those are the things that we actually need to pay attention to closely in those patients that we're managing. So in terms of chest pain, it's one of the common reasons for consultation in emergency department. And I can say that about 5 million patients are seen each year in the emergency department. And the presence of chest pain, I hope you are hearing what I'm saying, sir.
Yes, sir, we can hear you.
Yes, we can hear you.
All right, okay. What I'm trying to say is that the presence of chest pain elicits a lot of fear and anxiety because you want to be sure there is no underlying serious conditions like myocardial ischemia, myocardial infarction, coronary artery disease, which can result into sudden death in our patient, in such patients. So you want to be sure that those causes of chest pain are excluded on time. And as I've said earlier, that is a source of medical legal problem in the patient, in the doctor, because if the cause of chest pain is missed, the doctor can be sued and result into serious legal issues. And because of that, you want to do a lot of investigations, and the costs may be enormous. So in the emergency department, you want to sort out the patient efficiently and as fast as possible, so that those patients who do not have serious problem, they can actually be discharged. I remember in Ilorin, when I look at audit of echocardiogram that we did over a 3-year period, I think we echoed like 900 patients, and 5% of them had chest pain as indication. But only a few of them actually came up positive, that they really have something that will hold, especially younger individuals, because those are the one of the group that we see commonly. They will present with chest pain, but you do virtually most of the investigations from ECG, echocardiogram, troponins, and then definitely they don't have coronary artery disease. Okay, so we need to take a very a very painstaking on the patient, so that the cause of the patient can be determined as fast as possible. Now, I want to state some of the differential diagnoses that are actually related to chest pain. And if we talk about conditions that are associated with chest pain, basically from the myocardium, the heart. When you go out, you have, the myocardium, there's a typical way patient with coronary artery disease, they present. And then we also have the pericardium, they also have a typical way of presentation. And you can also have, causes from, what they call, from musculoskeletal system as a cause of chest pain. So the characteristics now, usually I'm going to go into that later, but you see, most of the patients who have chest pain that is related to myocardium, usually they will present with a dull or aching pain or feeling of heaviness in the chest or constricting pains, all right? So usually when they have that, this pain that usually brought on with exertions, and they tend to get better when the patient rests, all right? That is the typical history we get in the patient with coronary artery disease. Now, what about the pericardium? Pericardial pain usually is sharp pain and tend to change with coughing or position. Usually when the patient lies flat, the pain is increased, and when your patient sit up and bend forward, it tends to relieve the patient's pain. And so I'll mention some of the causes like respiratory diseases. Some patients with respiratory diseases like pulmonary embolism, meaning that they have a kind of thrombi formation in the lower limbs, and there's dislodgement of these thrombi, and then they kind of cause chest pain. And the other differential in respiratory system include things like pneumothorax, pneumomediastinum, pneumonia, bronchitis, and pleural irritation. All these ones can lead to chest pain. And then gastrointestinal system is another place, is another region where pains arise from and may be confused with myocardial infarction. Indeed, I had a patient, he's a white man who came with myocardial infarction. I think they came to Kwara State to undergo some of, to undergo some projects. And what the patient really had was more of pain in the, what do you call it, knee joint pains. That was the presentation of that patient. And that eventually, by the time he did ECG and did some other investigations, I think troponin, the patient was found to have myocardial ischemia, myocardial infarction, and he had to be referred urgently. All right, so all these ones are reflux esophagitis, another pain that we have to compare, that we have to differentiate from, that of chest pain, because they tend to confuse a doctor at times. So cholecystitis, pancreatitis, hiatus hernia, reflux esophagitis may actually mimic. And then we also have chest wall challenges. Costochondritis may actually be a cause of chest pain, and indeed many of the patients may fall into that category. So the possible cause of chest pain from chest wall outlined above. And some patient may have a psychological disorder, and the pain may not necessarily be there, but they are feeling the pain. Those are the various differential diagnoses. And as we have discussed before, I'm sure we are aware of risk factors for coronary artery disease, chest pain, and from 1948, when a group of doctors were actually set up to determine the risk factors for cardiovascular diseases among themselves and then their families. Okay, so that was actually the beginning of research for cardiovascular risk factors. All right, and they are in third generation now. Since 2002, third generation for research of coronary artery disease risk factor has actually come into play. And now, we have mentioned that there are specific, types of symptoms that we determine that we actually that we predict whether you are dealing with coronary artery disease, which is actually a very serious problem. And then the other ones that are not actually due to coronary artery disease are also there. And if the pain is sharp or dull, it's not likely to be coronary artery disease. Probably other causes of chest pain may come into play in this setup. You know, like a patient with costochondritis, I mean pain in the chest wall. Usually they have point tenderness. Actually, when they move the chest or the chest wall, these patients tend to have sharp pain or stabbing kind of pain. However, if the pain is, left-sided, is dull, is aching, and have all these characteristics on the left-hand side, probably the pain is central, or a feeling of pressure, is squeezing or gripping, or heaviness or tightness in the chest, that may also actually suggest coronary artery disease. And the more of this we have, so you can see towards your left side, the tendency to coronary artery disease is high. And towards the right-hand side, there are low risk factor for coronary artery disease. So we can use this one to actually classify the patient as urgent as possible so that appropriate treatment can be given to our patient. And then in terms of location, the typical location of pain is usually in substernal area or chest area. And with all those characteristics I've mentioned earlier, they are very, very important. Whether they are also radiating to various parts of the body, we are going to look at that very, very soon. All right. And sometimes you actually identify such patients, especially females. They may have submammary pain and you still be due to coronary artery disease. But commonly, if they have submammary pain, that may be related to mitral valve prolapse. And what is the quality of pain that we usually have in chest pain? A feeling of pressure, aching, constricting pain, and are generally thought to indicate ischemia. All right. However, qualities like sharp pain, stabbing pain actually decreases the likelihood of chest pain, coronary artery disease. And then we can also talk about severity, where there is really no difference between ischemic and non-ischemic pain. But usually they tend to have, for ischemic pain, acute ischemic pain, they have serious pain, and they have feeling of an impending doom. And many of the patients will be sweating. They have diaphoresis. So it's one of the ways we identify this patient with serious condition. If they have dull pain or aching or feeling of heaviness, and they also have radiation of the pain either to the jaw or to any of the arms, but especially the left arm, okay, then we'll think about pain. We'll talk about coronary artery disease. And then we talk about duration of pain. It's also very, very important. For example, those who have, unstable angina, probably the pain may just be like 5 to 10 minutes. And maybe, stable, you can predict the pain. For those who can, like probably after the patient have worked for like 1 or 2 NEPA posts, that is when they have the chest pain. Yeah, all right, this is typical of angina pectoris. And a chest pain that is coming for the first time and have all those qualities I have mentioned, you'll be thinking about unstable angina, because you don't know how this pain will terminate. All right. And for patients who have pain greater than 30 minutes, it's either that the pain is MI or the pain is non-ischemic. So duration is also very, very important. And for those who have point tenderness, or when they move the trunk, they feel the pain. You'll be thinking about musculoskeletal cause of chest pain. And for pleurisy, I've mentioned before, is related to, probably when the patient breathe, or when they take a deep, when they cough, they tend to have pain, but it's not likely to be ischemic, all right? So, and then the change in position of pain with position is also very, very important. I've mentioned before that pain of pericarditis is worse when the patient lie flat, and they tend to get better when they lean forward. I mean, sit up and lean forward. Okay, the pain tends to be low. But by the time you have a kind of chest pain that is high risk, definitely you have to actually look for the etiology, most likely of coronary artery disease. Now, of all of these chest pain, one of the causes that we want to exclude as fast as possible, we talk about coronary artery disease, and we know this can actually cause death in a very, very short time. And indeed, many of the patients are even, some of the patients, up to like 50%, may present with brought-in death. Okay, so that is why they must be evaluated as fast as possible. And some of the studies on coronary artery disease, we know coronary artery disease is due to development of atheromatous plaque within the coronary arteries. And we know from macrophages, they engulf fatty cells, and then they form, they form plaques, and they coalesce together to form plaques, and these plaques are the ones that cause narrowing of the coronary arteries. And by the time you have this, you can actually have what we call stable angina. The patient can actually predict when he was going to develop pain. And unstable angina is an acute, is part of acute coronary syndrome together with non-ST elevation myocardial infarction. And in this, there is partial obstruction of the coronary artery disease. And what usually happens is, as I'm going to show later, there is fissuring of the plaques, so that there's injury to these plaques or the rupture, especially those that have a lot of lipid core. And when this happens, these patients develop either acute coronary syndrome or they develop ST elevation myocardial infarction. And the coronary artery disease used to be very rare. And for example, a study done by Akpadijo et al. In Ilorin, he saw only a case annum, and then between 1984 and 1994, he saw 10 cases. I mean, they saw only 10 cases of coronary artery disease among medical admission in Ilorin. And I also review, between 2006 and 2009, and we saw 14 cases over a 3-year period, which was more than what Professor Akpadijo was saying earlier. And similar reports were getting from all over Nigeria and also other sub-Saharan Africa countries to show that actually the incidence of coronary artery disease was indeed increasing. And that led us to do another community study, which was actually presented in World Congress of Cardiology in Melbourne, 2014. And patients were actually asked what they would do if somebody developed a chest, if somebody developed symptoms and signs of heart attack. And okay, they made up their mind, but there's a gap between the onset of pain in the chest and when they decide when to go to the hospital. And we know that in many developed countries or many cardiac centers that have ability to do percutaneous coronary angiography within 2 hours within 90 minutes of presentation. This patient can actually have intervention to take care of their coronary arteries, but they have not been able to reduce the interval between the onset of chest pain and when this patient will make up their mind to actually present in the hospital. And is actually, as I've mentioned before, that time is actually muscle, because the issue of complications can come up and all kinds of challenges. So they have not been able to reduce when this period of, when patients actually make up their mind to present in the hospital. And even when they develop coronary artery disease, they tend to lose time from making up their mind to present in the hospital. And Nigeria Cardiac Society also mandated the group to actually also do, study coronary events in Nigeria. And in that study was championed by Osezo et al. Osezo was the one that led that study. And over 6 years, from 2013 to 2018, they were able to recruit 1,072 patients with age of 59 years. And they found that coronary artery disease, although it was not too common, but the incidence was actually rising. And those who have coronary angiography was about 42.4%, and just efficient therapy 70%, and the PCI was actually in 26% of patients, and this is all over Nigeria. That was the statistics we got from that study. And the kind of symptoms the patient have include chest pain, dyspnea on exertion, severe hypertension, dysrhythmia, cardiopulmonary arrest, and brought-in death were common presentation among the patient, and this is also our experience. But we know that the presence of cardiovascular risk factor, if it is not addressed on time, definitely will progress, to, a kind of cardiac remodeling, structural heart disease like atherosclerosis. And then before, you start having, thrombosis, and then eventually myocardial infarction, arrhythmias, remodeling, ventricular enlargement, and so on and so forth. So that is what we usually have. Hello. Sorry, somebody is making some noise. All right, and the pathophysiology, as I've mentioned before, is the rupturing of plaques. The plaques, when they rupture, they attract, they attract cells of inflammatory cells, and they can tend to form a kind of thrombi. And when they form thrombi, they further narrow the lumen of the coronary arteries. And basically, we have two types of, thrombi. We have a white thrombi, which are rich in, thrombin, and that is the type of thrombus we found in patients with, ST elevation myocardial infarction. So they tend to have complete obstruction of the coronary arteries, whereas white thrombus is formed from aggregation of platelets. So that is usually cause a partial obstruction of the coronary arteries. And that is why we don't give thrombolytic therapy to patients that have non-ST elevation myocardial infarction. Because if you give thrombolytic therapy, you're only going to dislodge the platelets, to those who have non-ST elevation myocardial infarction, and then we cause widespread thrombosis. So it's only patients that have ST elevation myocardial infarction that will benefit from. Sorry, I thought something. Okay. What did I touch? Sorry, I touched something. I want to put it on normal play again.
It is, Prof, it is showing normal play to us.
Are you seeing it?
We are
correctly?
seeing it. Yes, we are seeing it.
Yes.
Let me put it on slideshow again. I'm looking for a slideshow. As if.
Let's go back to your PowerPoint slide.
Yeah.
It is slideshow.
I've clicked on the slideshow. So, okay. Okay. So can you still see very well?
Yes.
Okay.
See the
So
slide.
these are the coronary arteries, and this is the top panel is normal artery. That is what we see in normal coronary arteries. You can see the flow is going, bifurcation is normal. And the second one, the middle one, is actually showing a narrowed coronary arteries, followed by a white thrombus. Hello? Hello?
Hello, sir.
We can hear
We
you.
can hear you,
We
sir.
can hear you, sir.
Somebody was talking. I thought he said it was not, I was too fast.
No,
Okay,
it's
so
not to you.
talk about, incomplete blockage of the blood vessels will produce acute coronary partial occlusion, and that is what is happening in the middle one. And then ST elevation myocardial infarction is produced by the lower one, and there's complete obstruction of the artery because of formation of thrombus that is already blocking the flow of blood in that artery. And okay, and this is how we investigate the patient. Symptomatic, low risk, we don't really do much for them. But for patients that have high risk or acute coronary syndrome, such patients are the ones that we have to do all the investigations that are available, depending on the local resources that is available in that environment. Okay, from ECG, and then we can also move to, exercise ECG, and for those who are possible, they will on lecture. I'm doing lecture. So for those who have acute coronary syndrome, they are the ones that will need percutaneous PCI, percutaneous coronary angiography to define the artery. Usually they go through what do you call it? The femoral artery that is, using fluoroscopy into the coronary arteries for them to determine which of the arteries is actually blocked or actually having, having blockade and then the infarction. And that is when, in the same sitting, patient can also have stenting so that they can open up the arteries, and then the stent, because they are also impregnated with some drugs to prevent, and from having reepithelialization and the blockage of that artery. So the selection will actually depend on local, what we have, the facilities that we have locally, like coronary, CTA, coronary angiography, for individual, for where it is available, coronary CT can be done, but the, how would I call it? The gold standard is to do coronary angiography to visualize which artery is actually affected. And then in terms of management, what we do when we make up our diagnosis, all right? Like I've said, ECG is very central to the diagnosis of coronary artery disease. Patients who present to the hospital with chest pain, all right? Majority of them do not have serious chest problem. And then we need to actually do these tests to be sure that they are stable and they don't have all those conditions. And the many of them, especially younger individuals, well, by the time we do ECG, most of the time the ECG will come out normal. And then when we come do troponin is also normal. And for stable patients, different protocols are also available for exercise CCG to determine whether they are having a myocardial ischemia or not. And for more than 70% of patients, when they are at rest, you know, there is the myocardial oxygen supply or demand supply is adequate, and they may not have chest pain. It is only when they do exercise that there is increment in myocardial oxygen demand, and patient will have pain. All right. At echocardiography, what we see is wall motion abnormality, and then when we do cardiac scintigraphy, you know, technician 99 sestimide, well, we can determine areas that are ischemic and whether the ischemia is reversible or not. At coronary angiography is the gold standard, as I've mentioned before. And now, presentation of the patient. As I've mentioned before, we have angina pectoris, meaning that we can actually predict what is actually happening. Patient probably work for one pole or two poles before he develop the chest pain. And then for non-ST elevation, it's usually difficult to differentiate from unstable angina, all right, because it is only when we do troponin I or T that we can differentiate, because both of them present with ST segment depression on the S3. But when we do troponin, you know, usually because in unstable angina, there is no myocardial necrosis. So troponins are normal. So that is the only way to differentiate that from non-ST elevation. So usually we call unstable angina a non-ST elevation myocardial infarction. We call it acute coronary syndrome. And then we have ST elevation myocardial infarction as a STIMI, all right? And they are the ones that usually do well or do on thrombolytic therapy. And usually within, we have mentioned before that within 90 minutes, many of the hospital will have, many of the patient or hospital who have facility for thrombolytic, PCI, they will have done PCI for the patient. But if it is not possible for them to have PCI within that minute, thrombolytic therapy will become very, very important. And this patient will actually need to have thrombolytic therapy with either troponin or retinoplase, and you know, before they have PCI or stenting. And then for those who have, you know, a lot of calcium in their coronaries, or who have coronaries that are not amenable to severe coronary disease, or those who have a lot of calcium in coronaries, they may need to have coronary bypass graft surgery. That is what we call CABG. All right, and this is very, very. Now, let's talk about treatment of pain now. Treatment of chest pain, basically, I'm sure that is the one that will interest us most. And normally we go through the use of simple analgesic for those, for non-ischemic pain. I mean, probably they're having musculoskeletal pain, or we have done some investigations and we found out that what they have is actually not related to myocardium. So we give them simple analgesic, including paracetamol, selective and non-selective NSAID can be given before we move to opioids. Okay, and these are the way we treat the patient. And then we are all aware of World Health Organization analgesic ladder. Usually there are 3 steps to this, but I think some authors are suggesting that there should be a 4th ladder. But I think this is more popular for now. I think in 2004 release, they were suggesting that probably will make another step. I mean, give room for another step. Otherwise, the commonest steps are 3. You know, if the patient has the mild pain, no opioid analgesic such as non-steroidal anti-inflammatory agent can be given, like paracetamol and co. Without adjuvant. Adjuvant simply we mean that you treat what is really causing the pain, all right, with the analgesic. And the second step is to use weak opioids such as hydrocodone, codeine, tramadol. You know, before some of these drugs are they are available in counter, but because of abuse, I think they are now also prescription drugs. They have to be prescribed before they are dispensed to the patient. And then the third step is to use for those who have severe and persistent pain, potent, opioids are usually used, either morphine, motadione, fentanyl, and so these are all the, agents that are being used to control pain in such patients. But we know that the use of nitrates is very, very important. Yes, nitrates, very, very important in this very patient. That will also reduce the pain in them. So these are the drugs for a patient with acute chest pain. Usually we recommend that they should take aspirin. You start even before doing any other thing, they should just commence with aspirin. All right. And once you commence with aspirin, and what you do will not depend on whether you are dealing with non-ST elevation myocardial infarction or ST elevation myocardial infarction. All right. Heparin, thrombolytic therapy, PCI, CABG, as I've described before, they're very, very important. But the last one, non-ST elevation myocardial infarction, they will not take thrombolytic therapy, because if they take thrombolytic therapy, they are likely to disperse the thrombi that will further cause widespread clotting, and which will make the outcome of the patient worse. So GTSP is what we use. Azoxystrobin dinitrate can also be used. And then beta blockers, which will reduce myocardial oxygen demand, like bisoprolol, metoprolol, carvedilol. They are very, very important. All right. And then we also use AC inhibitors or ARBs. AC inhibitors are best, but because of the side effect of cough, especially in Black patients, or angiotensin receptor blockers can also be used. And then we give antiplatelets. Antiplatelet is the one I mentioned before. Aspirin, clopidogrel, they're also given. And then statins for cholesterol. Actually, there are so many drugs that we can be given for cholesterol management. Okay. And then still on the treatment of pain, use of paracetamol is very, very, very important. But systematic reviews have shown that patients who use paracetamol, routinely or abuse paracetamol, they tend to have increase in blood pressure in patients with coronary artery disease. So it's not a drug we should just use anyhow. And that is what some people do. Once they have headache or anything, or they work and they are tired, the next thing is to want to use paracetamol. But I think paracetamol should be reserved for when it is necessary. Non-steroidal anti-inflammatory agents are also very, very important for treatment of pain, as I've described before. The analgesic ladder, very, very important. And then now for a patient with coronary artery disease, from a recommendation of American Society of Cardiology, European Society of Cardiology, right from 2015, the recommendation is the use of morphine. And oral morphine is the gold standard. The efficacy of most of the analgesic that we use in AMI is compared with against this, oral morphine is the gold standard if the patient can actually take orally. It is only when the patient cannot take orally that we use other parenteral agents.
The use of paracetamol increases blood pressure in some patients.
Yes. It's a systematic review of patient use of, patient use of paracetamol in patient with coronary artery disease. They found out that with time, their blood pressures are elevated. So there's increases in blood pressure. So that is their finding actually, but we don't know the importance of. So that is why we have to use them with caution. We don't just assume that it's a drug that we can use anyhow. And then, so it's a drug of choice. Morphine is a drug of choice, and it is only to relieve anxiety and dyspnea, all right? But it has a lot of drug interactions, okay? Especially with antiplatelets, it tends to reduce the efficacies, and that is why we have to be careful. But the side effect of morphine, we have drowsiness, constipation, and some of them may develop euphoria as a side effect now. and then nausea, vomiting, and respiratory depression. They are potential side effects of morphine. All right, and I think that is why they look at the drug actually to be used with caution, and that led to the search for alternative to the use of morphine. Fentanyl is another synthetic opioid, and it's very, very potent. It's like 20 to 40 times potent than heroin. You know, it's drug of addiction, and individuals are, but as compared with morphine, can be at least 80 times to 100 times more potent than morphine. All right, and I think it's usually useful for patients with cancer pain or recovery from surgeries, but it can also be used as an alternative to morphine. Some of the common opioids that is prescribed in myocardial infarction are listed, you know, from what do you call it? From buprenorphine to codeine to fentanyl, and you know their side effects and other things are listed in the table. We can look at, they have merit and demerit because of their, you know, in terms of potency, in terms of, and their actually potency is compared with morphine to your right hand side, so we can look at it very well. And then it's a continuation. And then I mentioned side effect of, okay, you know, they inhibit platelet aggregation, antiplatelets of effect of ticagrelor and also clopidogrel, morphine, and fentanyl. They delay the antiplatelet effect of those drugs. Some people have also tried lidocaine sodium, although it's an anesthetic used for analgesia and anesthesia. And it's also used for I think the parenteral form is also used for the treatment of ventricular arrhythmia. And in terms of efficacy, it's very, very efficacious in the patient with MI, but it's not commonly used, okay? So in conclusion, chest pain actually depends, the management of chest pain actually depends on the cause. We have talked about ischemic and non-ischemic chest pain. And I also mentioned that ECG plays a very critical role in the management of patients with myocardial infarction. And opioids are the drug of choice in the management of patients with ischemic heart disease. And the use of various modalities of treatment to also relieve pain, they act as an adjuvant to the kind of analgesia that we're using, like a GTN spray in the patient with myocardial infarction. So thank you very much. Yeah.
Thank you very much, sir. Thank you. Okay, Mr.
Yeah.
President, sir.
Okay, thank you very much, Professor Kulu. This has been a wonderful lecture, and honestly, I really benefited. And somebody was so touched that she has to restate the issue with paracetamol, this commonly used analgesic drug. I believe there are other questions. We are really grateful, and the secretary will now go lead us into the Q&A session. So please, if you have your question, raise up your hand, and then you can type your question into the chat box. I know that if people have been asking for recording, yes, we have a YouTube channel for SSPN, so please watch out. Be our member, and then you will see when the link is out. Thank you. Dr. Dada, it's over to you.
Thank you very much, sir. I want to quickly take Dr. Akinwale MO, so that we can use up the time that we have. Dr. Akinwale, you have a question, please.
Yeah, thank you. Good evening, sir. Good evening. Thank you, Professor Pro, for the lecture you gave. I just want to add that this pain, they sometimes cause an emergency. When they cause emergency, you talk about the normal, we use what they call pneumonic pneumonia. is morphine, oxygen, nitrate, and aspirin. Because when they come, they may be dyspneic, as I've said, they may be they're anxious. So when you do the SpO2 and it's low, you need to also give them oxygen, apart from giving the nitrate and the morphine and the aspirin. That's my comment, sir. Thank you very much, sir.
Yes. Well, I was just minding my time, but oxygen is one of the things that we give in acute emergencies, especially if the oxygen saturation is less than 94%.
Thank you very much, sir.
Yes, sir.
Well, just like we have seen, I think that will be time that we may have to come together like a workshop to deal with some of these issues. We know that within 1 hour, we might not be able to totally do justice to some of them, but we appreciate what you've done. And let's have some. Let me see whether there are some in the chat. If you have a question that you want or a clarification you seek.
Yes, I have a question, Dr. Dada.
Please go ahead, sir.
Okay, thank you so much once again, Prof.
Yes, sir.
You show us how chest pain, the incidence has increased over the last 20 or 30 years. And we saw how within a 3-year span, it's increased so tremendously, more than 300 times. What do you think is the real reason why there is an increase in chest pain, incidence of chest pain? And is there any way we can mitigate? Because we are talking about community health and disseminating this to the society.
Thank you very much for the question and comment. I want to appreciate you for the comment. Actually, what we have discovered is that in our societies, we tend to live like, previous studies that were done in early 70s, 80s, and early 90s clearly show that we have less of, hypertension, diabetes, all this coronary disease. They are not problem of Africans. But by the time we start living, eating diet that excludes, we frying everything, eating a lot of fatty meals, and you see our younger people accumulating weight. So those are some of the reasons where we are having more cases of coronary disease in our own environment, because we have adopted westernized lifestyle. We do less of exercise with food like white men. Okay, so those are the risk factors. The fact that we take saturated fatty acids, the fact that we do less of activity, increase our body weight, actually increases the risk for coronary disease. And that is why we are saying that at the community level, we need to intervene so that we have less cases of coronary disease. And the fact that we take less of, usually what we tell them when they come to our clinic is like they should avoid red meat. All right, and many of them will not eat cow meat again, but they'll be eating intestines, liver, and pole. They will abandon the red meat, and they will be taking the organ meat, and those are also very, very rich in saturated fatty acids, and it's increasing the burden of coronary disease in our environment. And we also know that the use of milk. Okay, we know that because even if you don't take fatty meat, at least we have chicken, we have other birds, and all kind of fish. Whether you are talking about dry fish or wet or fresh fish. In fact, fish that has a lot of oil, we usually recommend those ones because fish oil is protective. They tend to protect against coronary artery disease. All right, so those are the kind of meat that we recommend. And we also recommend that if they are taking milk, they should take skim milk, the milk in which they have removed the cholesterol, skim milk, they will have them in the market. And also if they are taking eggs, the white component of the egg is okay, but the white aspect has a lot of cholesterol. So, and then they do more exercises, they eat a lot of fruits and vegetables. That will definitely help in the reduction of coronary disease. And then they also need to control their blood pressure. And for those who have diabetes, they also need to control their blood sugars. But those are the things that we have observed that they are making coronary disease to be more in our environment. Thank you.
Thank you, Prof.
Yeah.
Thank you very much, sir. Let me read one of the charts.
Okay,
so this is a very interesting presentation. Thank you. Mechanistically, how do insects increase the risk?
How does
any comment on the effects of paracetamol on BP in patients with CAD?
Yeah. I wouldn't know the mechanism, but the I think they observe some patients, especially if they observe the use of paracetamol over time. And they develop that, I think they compare those who have, those who use paracetamol and those who do not use paracetamol. And that systematic review actually shows that those who use paracetamol commonly, they develop systemic hypertension. That is their finding actually. And I don't know how that will actually come about. But that is their finding actually. So that is why we have to use even paracetamol with caution. And especially would educate the patient not to abuse paracetamol ahead of time in case they will need these drugs for treatment of coronary disease.
Blood pressure increase in CAD?
Yes. Actually, it's a finding from a meta-analysis. They compare some studies and they found out that those who are using a paracetamol eventually develop systematic reviews shows that use of paracetamol was associated with elevated blood pressure. Is their findings.
Thank you very much, Prof.
Okay, sir.
Thank you.
Yeah.
Well, okay, I think a question just came in now.
Okay.
Dr. Dr. Babatula, that's from the UK. I'm happy that the Prof mentioned the strong opioids, such as fentanyl. I hope we will be very careful with the strong ones because of the prospects of abuse. Lidocaine infusions have also been shown to be effective in managing intractable chest pain. Dr. FDO Babatola.
Yeah. Well, you know, even the one that would classify as for us to be used in the step 2 in the management, WHO step 2 in the management of pain. You know, most of these drugs, are you talking about tramadol, codeine? They are not readily available, except you have they actually dispense on prescription because they have noticed abuse all over the place. All right. So fentanyl is very, very potent, and I think it's very, very useful too. And compared with morphine, it's like 80%, 80 to 100% more potent. And indeed, I think the recommendation is, apart from this coronary disease, usually patients that have cancer pains, those are the indications for its use. But it's also another form of morphine. I gave a list of morphine that is commonly, opioids that is commonly prescribed, although fentanyl is there, yeah. But I think it's only when it is prescribed that is they are dispensed. And I think they are drug of addiction. And it's just like heroin, and it's even more potent than heroin, 20 to 40 times more potent than heroin. And that is why we have to be more careful in its prescription too.
I think there is one question,
Okay.
Dr. Dada. Yes, he said there's a question that says, how readily can we assess the thrombolytics?
Okay. Thrombolytic in Nigeria, I won't say they are not available. They are available, but they are out of reach of common man.
Oh.
The one that is available before is streptokinase, but we know that streptokinase, in younger individuals, we don't usually want to use it because of the fact that they develop allergic reactions. And retinoplase is another, but it's too expensive, way too expensive for some of our patients. Because I know I was asking recently about the cost of, I went for accreditation somewhere, and they used retinoplase occasionally, and they are saying it's above 1 million. So it's quite expensive, and that is what I think what we used to do in Ilorin before. We had this arrangement with I think Boringa. They will keep the drug, and whenever we need it, we call them within a very short time. They will ferry the drug to us, but the cost is just too much, especially with this devaluation of Naira now. That is the reason why it is not readily available. Yeah.
Thank you, Prof.
Thank you.
Dr. Dada, are you back? There is a question here that says, okay, there's one question from Dr. Ibrahim Musa. Can you see it?
Yes, that's what I want to read now. It's asking for collaboration. He is a biomedical scientist, and it's saying
biomedical science.
Biomedical.
Okay. Engineering.
He said it's curious how biomedical scientists can collaborate with clinicians in order to be well informed about where the pendulum should be swung in case of our research priorities, talking about disease mechanism and drug discovery scientists.
Oh, Prof, we cannot hear you.
You are muted, Prof. Professor Okolo, you are muted, sir.
Okay, yes. Prof. Kolo, you are muted.
Hello?
Yes, we can hear you now.
You said?
Yes, we can. We can now.
Yeah. So the issue of biomedical engineering, biomedical engineering, they are very, very important. But the only challenge is that I think is it that we expect more from them in terms of some of the instruments that we use, especially in maintenance. I wouldn't know, like some of the machines that we are using in the hospital. If they have a problem, we usually expect that if they send this to biomedical engineers, we expect them to repair this equipment for us to be able to use them. But many times in our environment, probably they don't have the training. Once we have many of these machines having problem, we just drop them. They can go to biomedical engineer and they can't really do much. For example, let me talk about our defibrillator. There was a time they donated defibrillators to us, I think 2018 or 19. And of late, we discovered that many of them, their batteries are not working again. And we expect that the biomedical engineers will be able to rescue us, either to change the battery, but we are not able to get it done. So those defibrillators are just there for nothing. And even if we buy another one, it is a question of time that those batteries will also run down again. But for the biochemical research, definitely we need to collaborate with them with the kind of especially in designing the equipment that we need for some of this research. It is very, very important. And but the capacity is still not, it's not enough. It's not really there yet. And that is why probably the collaboration is not enough yet. But I think once we have capacity building, equipment, I think we should train with them more in terms of research and so on and so forth. But in our engineering, they have not been able to do much for many of our equipment. And many of them, some of them, they don't have a maintenance agreement with the companies. And probably that is one of the factors that is helping us to get, that is making us not to get what we want from them. But those are some of the experience that we have. Thank you.
Okay, so lastly, Professor Onwaso, please.
Thank you very much, the presenter. I want to congratulate Professor Kolo. He's my alumnus from ABU. Well done. It was a very, very good and stimulating presentation, and I really appreciated it very well. I want to just ask about the access. How is the availability of CABG for patients who need it in Nigeria? How feasible is it, and how are the patients able to access it?
Well, before, they were not really available. But of late, I think many of the hospitals are coming up, especially in the private setup in Abuja and in Lagos. You know, like Cardio Care Hospital in Abuja, First Cardiology Consultant in Lagos, and then Tri-State Hospital in Lagos too. But many of the teaching hospitals, they are not able to do that. Many of them, the facility is not just there. So, but the private setup is available, but the money, the funds are not, is a major constraint, because those ones will not do it for free. They will need to have, you know, what do you call it, a fund, especially when they are to purchase, you know, okay, you know, when I was talking about PCI, but for CABG, you know, they are available, but the cost of the procedure is post-operative care, and also the procedures, they are available, but the cost is prohibitive. Otherwise, they are beginning to show up in Nigeria now, especially in private sector.
Thank you very much, sir.
Yeah.
Thank you very much, ma'am. Thank you for your question.
No
we want
problem.
to appreciate you. I will hand over to the president so that we can do the. Thank you very much, Prof.
Yes, sir.
Once again, thank you very much, Professor Okulo. I'm so delighted that you honored this invitation, and it's so stimulating and interesting. Just to say a few things about our society. It is the Society for the Study of Pain, Nigeria, and as you can see, it is multidisciplinary. I'm a physiologist, neuroscientist, and my secretary is a physiotherapist. And we have my two vice presidents are anesthetists. So we have nurses, everyone that is involved in the study of pain. Now we talk about pain, how to do research about it, how to do treatment. Last month we were talking about pain in the head and neck region, and next month we are going to be talking about pain somewhere else. So I want to encourage every one of us to take up membership of the Society for the Study of Pain in Nigeria. We are affiliate of the International Association for the Study of Pain, and I also want to say that we this month of September is the Pain Awareness Month. So we want to disseminate information about how to take care of pain, treat pain, and then we'll continue to do the good work that we can. I want to once again appreciate our presenters, and I can see a lot of big-time professors. The Deputy Vice Chancellor, That's Professor Fawale is here. That's research RTS, and other professors are also here. We want to appreciate all of you for coming. The immediate past president is also on the call. Thank every one of us for all the effort, and we appreciate your time. Please join us next month when we have another specialist talk to us about pain research and management. Thank you very much.
Thank you very much for the invitation. Yeah.
Hello. Hello.
Dr. Akinwale, yes, you can go on. Dr. Akinwale, all right, thank you very much. I think that's the end of the lecture. We appreciate you once again.
Hello, my president.
Okay.
You can unmute and greet.
Dr. Opeyemi Babatola.
Dr. Paul.
All the way from UK.